Good morning, everyone. Hi, welcome to breakfast at UMHealth. So this morning, we are very pleased to have Dr. Wei Ping, a neurosurgeon from Hospital Kuala Lumpur. Dr. Wei Ping is a guest of mine. She will be speaking on a number of issues relating to the central nervous systems. In particular, in parasitology, we're of course very interested in parasites that might infect the central nervous system. And HKL being the premier hospital of the country, they see many different types of cases. Dr. Ng is very well known among her peers. She is highly respected by her big boss, the boss of all neurosurgeons at HKL, Mr. Amir alias. I'm very pleased to know Dr. Ng. She has a master of neurosurgery. She's also has outstanding leadership and multiple professional commitments, amongst them the Epilepsy Surgery Workshop, Neurosurgical Association of Malaysia, the educational course, ISPN educational course in Kuala Lumpur, the WFNS Symposia, and she's also highly active in patient groups. Dr. Wei Ping personally had carried my wheelchair down a flight of stairs in 2019 in Johor. So please give her a warm welcome. It's very nice to see other professionals from various disciplines come into UM and grace our breakfast at UMHealth. The floor is yours, Dr. Ng.
Okay, thank you, Dr. Aisha, for the kind introduction. I would like to share my screen now. First of all, I would like to thank Dr. Aisha for inviting us to participate in the UM breakfast talk. So I would like to thank Mr. Azmi also for giving me this opportunity to share my experience in managing patients with CNS infection. So the topics today is CNS infection, the role of a neurosurgeon. Okay, these are the outline of my presentation. So I will talk about introduction, the basic concept that we need to know when we talk about CNS infection, a bit on meningitis versus encephalitis, and the commonest CNS infection that neurosurgeons normally encounter, of which include cerebral abscess, subdural empyema, ventriculitis, CNS tuberculosis, CNS toxoplasmosis, post-operative infection, spinal surgical infection. Okay, so for introductions. So central nervous system infections means that the infection mainly affect the brain and the spine and also their covering membrane. So the commonest organism include bacteria, virus, parasite, and fungus. So the commonest conditions that happen in CNS infection include meningitis and encephalitis. Most of the time, these two conditions will be managed by ID team, neurologist, or general physician. But when a patient develops brain abscess, empyema, or other complication of central nervous system, the patient will be referred to neurosurgeon for intervention. The presentation of central nervous system infection may be acute, subacute, or chronic, all determined by the anatomical location of the infection, the pathogen, and also the host response. Okay, these are the basic concept of what I call that we need to know when we talk about central nervous system infection. So I used to tell that brain is actually very beautiful, but somehow when central nervous system infection set in, you will see a lot of horrible intra-op findings, of which I will show later. Hopefully it would affect subsequent days of your work. Okay, so to learn about CNS infection, we need to know brain, we need to know spinal cord. So the brain and spinal cord, they are covered by a layer what we call a meninges. So the brain covered by cranial meninges and the spinal cord covered by a spinal meninges. And they are protected within a skull bone and also a spinal canal. So the dura will form a venous sinus for the venous drainage. and what I call the the subarachnoid space, what I call the arachnoid will project into the venous sinus for venous drainage, and the subpyometer will continue with the Baccharoidal space. Okay, so within the brain, we have a CSF, cerebrospinal fluid, and the cerebrospinal fluid will circulate from the lateral ventricle through the third ventricle and fourth ventricle, and eventually exits via the subarachnoid space and through the arachnoid granulation and go back into the venous drainage. So variable structures that within a skull, it can get infected by organism, bacteria, virus, parasite, or even fungus. The physiologies of cerebral CNS system will be the specific part of the vessel. So this vessel, it contains of what I call a tight junction of the endothelial. Basically, its outermost endothelial cell, it forms a tight junction to prevent the infection sets into the central nervous system. But when there is a breakage in the tight junction, once we get CNS infection. Okay, so I will talk briefly about meningitis and encephalitis. So, okay, meningitis means that meninges will get infection. So, patchy meningitis is the dura get infected, whereas the leptomeningitis, if let's say the infection only affect pyometer and also arachnoid. So meningitis can happen via hematogenous spread from the lung, from the abdomen, from the heart, valvular vegetation or cyanotic heart disease, or via direct extension. It can be divided into acute and chronic. Most of the time, acute pyogenic meningitis caused by bacteria, acute lymphocytic meningitis caused by viral, whereas chronic meningitis caused by fungal, TB, or parasite. The infection will enter into this protective layer of the brain, what we call the meninges, through hematogenous spread or axonal transmission. So, whereas encephalitis happen when brain parenchyma get infected. So the difference between meningitis and encephalitis is they share the similar presentation. A patient will get fever, headache, whereas in meningitis, one tends to get neck stiffness and photophobia. For encephalitis, the brain will get dysfunction. Once we present with a seizure, the auto consciousness or neurological deficit. So the diagnosis mainly by lumbar punctures. So as in a bacterial meningitis, pyogenic meningitis, the CSF will show a high total white cell, predominantly neutrophil, low glucose and also high protein. Whereas in a viral meningitis, the cell count increase mainly predominantly lymphocyte. Glucose may be normal, protein normal or high. The commonest, what I call community-acquired meningitis agent include Streptococcus pneumonia, Neisseria meningitis, Group B Streptococcus, Listeria, and Haemophilus. Whereas Staph aureus and Staph epidermidis is more common in penetrating injury or what we call post-surgical. Okay. Viral infections caused by herpes simplex, varicella zoster, and also JE. Of course, imaging are important when we talk about meningitis or encephalitis. There will be leptomeningeal enhancement. There will be signal changes in the brain parenchyma if encephalitis sets in. Okay, so now neurosurgeon will have to step in. If let's say complication happens from a simple meningitis or encephalitis, or if the medical management, antibacterial, antiviral, antiparasitic fail, and when a patient presented with infection, but diagnostic dilemma arises. So as a neurosurgeon, I will need to bring the patient into theater. I will need to open the skull to see what is inside. And I will need all these instruments, as well as a junk-like microscope. Okay, so I will talk about cerebral abscess. Cerebral abscess is a focal pyogenic infection of brain parenchyma. So the central nervous system can be invaded by contiguous focal infection. A patient with a paranasal sinusitis, mastocytitis, otitis media can prone to develop cerebral abscesses. Of course, cerebral abscesses can also be caused by hematogenous spread from the lung, from the what I call the heart and also the pelvic. And if let's say a patient's sustain a head injury, especially open skull injury, direct inoculation of the organism can happen. However, up to 15% of the cerebral abscesses actually cannot find any causes. Commonest pathogens include Streptococcus, Staph aureus, Bacteria, or Enterobacter. So a patient that presented with a headache, fever, altered consciousness, and most of the time, because the cerebral abscess is located within the parenchyma, one tend to get a localizing signs. Laboratory findings can can detect probably raised ESR, raised CRP, or mild leukocytosis. Blood culture sometimes may be negative. For imaging, most of the time we'll be able to see a single or multiple ring enhancing lesion. Okay, there are 4 stages of cerebral abscess. So early cerebritis, late cerebritis, early capsule, and late capsule. What we call stage of 4, basically the rules of 4. Neurosurgeon only start to intervene when late cerebritis, early capsular, or late capsular phase. So we can do aspiration of the pus via a needle puncture, via a burr. If let's say the lesion causing mass effect in the late capsular phase, we even can excise the lesion. Okay, so treatment wise, basically most of the time is medical management, especially if let's say it's early capsular, early cerebritis phase. Antibiotics 6 to 8 weeks with or without steroids. Steroid is still remain controversial unless the edema is really marked, or most of the time we try not to use steroid because the steroid will tend to actually worsen the immune status of one patient, and it will also delay the formation of the capsulated phase. So medical management step in only if let's say the lesion is small, the lesion is located in a poorly accessible site, example brainstem, early cerebritis phase, or if let's say the patient is a poor surgical candidate with multiple comorbid and unfit for under general anesthesia. So as a neurosurgeon, we will step in if let's say the cerebral abscess causing mass effect and proximity to ventriculitis, because once the abscess rupture into the ventricle, the patient will tend to develop ventriculitis. And if let's say the abscess contains a foreign body, and the abscess is more than 2.5 centimeter, causing mass effect and raised intracerebral pressure. So the follow-up of management of cerebral abscess mainly depends on the clinical and also imaging. So the clinical wise, patient's clinical condition, as well as the the blood parameter, the CRP, total white cell, and also imaging, we will be looking at the degree of ring enhancements, the mass effect, edema, and the size of lesion following management. Okay, so I will need to show how we do aspiration as a neurosurgeon. So basically, aspiration is attended when the lesion is deep-seated, thin wall, and multiple. So what normally we do is we will do a burr hole and put a open a dura and put a needle puncture inside the brain and aspirate it. So this imaging is before aspiration of the abscess, and this is the after aspiration of the abscess. Okay, excision. So what happened is, if let's say the lesion is causing mass effect, causing raised intracranial pressure, so we will, and also the abscess is sizable, late capsular phase, we will need to open. Open means that we do an open craniotomy, we remove the bone, open the dura, and we excise the abscess. So this is the imaging that after excision of the abscess. Okay. Second commonest conditions that we encounter will be subdural empyema. Subdural empyema means that the accumulation of the pus is beneath the dura. The abscess, the pus will spread over the convexity into interhemispheric fissure. So it can result from the meningitis, it can extend from the sinusitis or otitis media, and it can happen due to trauma or post-surgical. Common pathogens include aerobic and anaerobic streptococcus. Most of the time, because you imagine the brain is so within a confined cavity, and the surface are all pus, a patient will definitely will be unwell, and they will develop rapid progressive on neurological sign. So the CRP ESR will be high. The imaging wise, there will be enhancement of the subdural correction over the cortex. So bear in mind, subdural empyema is always surgical emergency. So what happens if, let's say, we don't address the subdural empyema, one tend to go into refractory status epilepticus, because the brain tends to swell, subsequently cortical vein thrombosis, the brain tends to infarct. We lose a patient previously when the patient referred late to us from private side, from what we call district hospital. Okay, so what normally we do is, if let's say the subdural empyema is just very small over the frontal part, probably you can do a borehole and drain it, but most of the time we will need to open, means that do a proper craniotomy, wash out the what I call the empyema, evacuate the empyema. But then most of the time there will be a layer of a capsule that tightly adhered into the brain, of which we can't remove, and a brain will tend to swell, of which we need to leave the skull bone outside. So the third condition that commonest that we encounter in what I call neurosurgical field will be ventriculitis. So ventriculitis means that there will be inflammation of the ependymal lining of the ventricle. So it can result from the brain abscess. Like I mentioned before, the abscess that located near to the ventricle, it tends to rupture into the ventricle and causing ventriculitis. And it also what I call can be caused by an intraventricular catheter. So as an what I call in a normal neurosurgical practice, putting external ventricular drainage, putting a catheter inside the brain is common. So all the pathogens will tend to set in, include Streptococcus, gram-negative bacilli, Staph aureus, and cons. So most of the time, the patient will develop autoconsciousness. When ventriculitis associated with meningitis, the patient will have a meningism sign. So the imagings that we, what I call the common finding in imaging, there will be ependymal enhancement. There will sometimes what I call a patient tends to have an intraventricular localization on the imaging. The prognosis will definitely be poor. We have up to mortality of 30%. Okay, so conventionally, when a patient develops ventriculitis, we used to make a skin incision in the scalp, then we open the bone, we put a catheter inside and lift the catheter. So to drain this catheter that subsequently anchored to the what I call skin when we close the skin incision, and it will continue draining the CSF. So the catheter O's that live outside, basically we can use to drain the CSF that contains what I call infection, and also we can even what I call inject the antibiotic through the catheter in through the ventricle. So the main purpose of the ventriculostomy is for CSF analysis, drainage, as well as reduce the load. So however, nowadays, because the ventriculitis mortality is very high and patient will require revision. Normally, when the patient develop ventriculitis, require a ventricular drainage, external ventricular drain, will need to be revised every 10 to 14 days or maybe longer, what I call earlier, depends on how bad is the clinical condition of the patient from the what I call clinical feature as well as the blood parameter. But what happened is the skin we need to open back and reclose back, and we continue changing the catheters. And we have to repeatedly bring the patient back to operation theater. So nowadays, we will tend to shift to endoscopic lavage. So endoscopic lavage means that we will need an external device, the endoscope. So I will talk what I call a bit on the endoscopic lavage, what we used to call a brain wash. So supposedly brain is the most what I call beautiful organ, and the ventricle, the CSF inside the ventricle is actually a clear color. But somehow when ventriculitis set in, you will see all this fluff, all this pus sediment, and all this, imagine, is inside one's ventricle. So by doing endoscopic lavage, or what we call brain wash, basically we will remove as much as possible what we call this, the mud, the sediment, the pus from the brain, and subsequently it will shorten the what I call the duration of antibiotic, because it facilitates drainage, reduce the bacterial load, and what I call currently one of our master student in HKL is doing a study regarding endoscopic lavage in pediatrics. Hopefully the paper will give what I call excellent outcome later. Okay, So fourth commonest what we call CNS infections that neurosurgeon encounter will be CNS tuberculosis. So the pathogen is mycobacterial tuberculosis. The risk factor includes malnutrition, HIV co-infection, and immunosuppressive drugs. So it can manifest as a meningitis, tuberculoma, abscess, hydrocephalus, vasculitis, infarction, or spinal column what we call invasion, like what we call Pott's disease. So I will talk about tuberculoma. So tuberculoma basically is a space occupying mass within the brain parenchyma. Up to 30% are asymptomatic. So the clinical feature depends on the location and also the site of the tuberculoma within the brain. And 60% only will stain positive. Imaging wise, once we see a target sign. Of course, histopathological examination wise, you can see or what I call a granulomatous inflammation with a central caseous necrosis, contains of epithelial and multinucleated cells, and treatment is definitely anti-TB. So, but hydrocephalus also are commonly encountered. Most of the time, what I call infectious disease physician will refer us to shunt the patient. What happens is in TB meningitis, the inflammatory infiltrate within the subarachnoid space, causing disruption of the CSF flow. Either communicating what I call hydrocephalus can happen, or non-communicating hydrocephalus. So of course, to address the hydrocephalus, I will still need a device, and I will still need to drill a hole into the skull and put a catheter, and subsequently what I call this catheter will pass beneath the skin all the way tunnel and through the chest and put the catheter within the abdomen. So fifth most common CNS infections that neurosurgeon encounter will be CNS toxoplasmosis. Yes, CNS toxoplasmosis, we know that the protozoan, what we call Toxoplasma gondii is the commonest organism. But then what happened is, okay, if let's say a straightforward case, CNS toxoplasmosis, straightforward diagnosis means that a patient with HIV infected, CD4 count less than 100 cells. In the radiological finding, what I call, there will be more than 5 ring-enhancing lesions that located in the basal ganglion thalamus eccentric target. Then yes, it leads to it gives rise to CNS toxoplasmosis. And the serology will detect anti-toxoplasma gondii, of which peak at 6 to 8 weeks, with molecular study detect a PCR, and the what I call, if let's say the diagnosis is correct, so it should respond to the anti-toxoplasmosis treatment within 2 weeks. The CNS toxoplasmosis will manifest as headache, fever, seizure, focal neurological deficit, and autosensorium. But bear in mind, so when the HIV positive or immunocompromised patient, they will tend to develop all these differential diagnoses, CSF lymphoma, what we call cytomegalovirus, and CMV. So the diagnostic dilemma happens when there's only single lesion, negative serology, not respond to empirical treatment. We will still need to put a biopsy needle and take a biopsy to guide in terms of management. Okay, post-operative infection. Basically what we say, it could be iatrogenic, it could be originally the infection already stepped in before we intervene. A patient will tend to develop fever, local erythema, tenderness, wound adhesion, and pleural discharge. So treatment most of the time is surgical drainage, debridement, removal scalp bone flap, prolonged antibiotic, and chronoplasty later. Okay, so what happened is this patient sustained an open head injury. We went in, do a proper debridement, remove the bone fragment, proper skin closure. 2 weeks later, the patient developed wound breakdown. There will be a lot of pus coming out from the wound. When we open, you can see all this pus is just coming out. The wound breakdown despite on antibiotic. We also have patients that we take out the tumor and we remove the bone that invaded by the tumor, we replace with titanium mass. But then during follow-up, months, years later, patient come back with skin eroded by the implant and infection sets in. We also have cases that cranial osteomyelitis happen when a patient underwent any neurosurgical procedure, subsequently non-healing wound with persistent discharge from the scalp. Then we need to remove the infected bone. Of course, neurosurgical intervention include also we remove the clot in ICP. We take out the skull bone in infarct patient, but then the wound can come back with breakdown of which you can see a lot of all these like pus and all these like what you call sediment, and also the brains will tend to swell. Okay, so spinal surgical infection most of the time is incisional and soft tissue type. Yes, it can affect osteomyelitis, epidural abscess and ascites can happen, but very, very low percentage, only 1%. Similar roots infection also same like cerebral infection. Common pathogen include staph aureus, risk elderly, obesity, diabetes, prolonged surgery or prolonged hospital stay. Of course, different types, they have a different clinical manifestation. So management-wise, mainly for microbiological diagnosis, neuronal decompression, and also spine stability. Okay, so we intervene a lot, but then there is also a condition when we need to call a stop. Yes, we were being referred cases for CNS infection, but there are cases that we can't do much. This patient will refer from other hospital to us. So what happened is the patient will develop a mucormycosis that infected the craniospinal and entire skull base. So in this patient, we can't intervene. Okay, so in conclusion, central nervous system infection and the sequelae posted life-threatening with high morbidity and mortality to a patient. Prompt recognition and treatment are crucial. If in doubt, consult neurosurgeon on call. Thank you.
Thank you, Dr. Ng. That was an absolutely brilliant presentation. Thank you, Dr. Ng. Are there any questions? So we're leaving the questions towards the end. So I pass it over to the next speaker, your moderator.
Dr. Aisha, you can ask the questions first because then it'll be a different topic right after this.
Yes, I thought we were keeping all to the end. All right then. Okay, that's lovely. If there's no question from the floor, because I don't see anything coming from the chat, I will ask my own questions. All right. So Dr. Ng, you are of course a female neurosurgeon. You're a woman in STEM, and that's really highly remarkable. Well done. Can you please let us know perhaps a little bit your own personal experiences, how this affects you, your life, and you know, in general, do you feel that women make better neurosurgeons?
Okay. How to call? Okay, I still remember the first day I went to what I call our master neurosurgical interview. The first question I was being asked by my professor, which is why you want to be a neurosurgeon? Are you planning to get married? And if you get married, can your husband accept you have a busy life? And if let's say what I call you are in the theater operating, suddenly your phone call ring, your son fall sick, then what will you do? Of course, it's challenging to be a neurosurgeon, but to me, I feel like if you like this career, you will try your best, no matter how. To me, patient is important. Yeah.
Lovely. We have some questions in the chat. I'll just very quickly, because pick the important ones. There's a question from Prof. Tunku Sarah. Why can't you intervene with fungal infection?
Okay. We can intervene fungal infection, means that fungal CNS infection. The last case that actually I mentioned, the patient was referred to us initially. We had an MTT meeting, and what I call involving what I call the maxillofacial team, the plastic team, the ENT team. But somehow what happened is, bear in mind that if let's say early stage of infection, yes, we can intervene. We can remove the osteomyelitis bone. We can excise a fungal infection. But what happened in that case, basically the whole entire cranium, the cranium and also the skull base are invaded by the fungal. And the patient also having what I call the whole spine infected by the fungal, and the patient is already paraplegic. So the question will be, if let's say we intervene, what kind of outcome that we want for this patient? So that's why we decide not to intervene in that case.
Okay, thank you, Dr. Ng. Looking at the time, if you could,
Yes.
kindly answer in the chat box, that
Sure.
will be very helpful. I will pass it over now to Dr. Intan.
Thank you, Dr. Aisha. Okay, I think now we move on to our second topic for today. The second topic is titled Emerging Tobacco Product, Heat Not Burn. Okay, this topic will be presented by my esteemed colleague, Dr. Muhamad Alfakri, who is a medical lecturer from the Department of Anatomy and also a member of the Nicotine Addiction Research and Collaboration Group, This talk will be, dissecting the different types of tobacco product on the market and whether they are good or not based on research done by the International Tobacco Control Policy Evaluation Project. So let's warmly welcome Dr. Alfakri to the floor.
All right, thank you, Dr. Intan. I hope you can hear me and look at my presentation. Assalamualaikum and good morning. Thank you for the introduction and thank you, Breakfast at UMHealth, for this opportunity for me to share on this topic, the emerging tobacco product. Heat not burn also can be called heated tobacco product. This is a new tobacco product and started to gain popularity since 2014 and currently available in our country since a few years ago. As we know that tobacco use, in particular cigarette smoking, cause adverse health effects. This is associated with a number of diseases such as coronary artery disease, lung problems, and many cancers. Therefore, tobacco use is cardinal and preventable cause of premature death. Reportedly, 7.1 million from 8.1 million deaths caused by smoking cigarettes. And not only that, an estimate of USD 2 trillion per year, which equivalent to 2% of world total's economic output, is associated with tobacco use. On top of that, cigarette smoking also cause severe environmental impacts. For example, air pollution and also littered cigarette butt may seep into our aquatic ecosystem and pollute the water system. One of the most effective ways to save lives and improve overall well-being is not to use tobacco at all costs, and successful tobacco control can save millions of lives. However, sadly, less than 5% of smokers succeed in quitting smoking for a year on their own. The tobacco epidemic remains most challenging despite various measures for prevention, and this is because of nicotine addiction, making it challenging to stop smoking. Yet tobacco is legally sold in virtually every country in the world, and after decades of understanding its harm, and it remains not only legal but highly accessible and profitable, especially except to the consumer. And because of the harmful effects of cigarette smoking, the tobacco industry has evolved and come out with a new tobacco product which claims to be less harmful or reduce harm product. And this is important for the tobacco industry players to remain relevant with the idea to minimize the harmful exposure to tobacco among active users. However, I would like to emphasize that tobacco use of whatever forms has no health benefits, no moderation in tobacco, unlike the alcohol. There is no level at which tobacco smoke is safe for the consumer or for people around them. As we know that electronic cigarettes are one of the latest alternative to combustible, as we know that the electronic cigarette, also known as vape, or in particular nicotine vaping product, or also can be called as electronic nicotine delivery systems, has been introduced to the market in the early 2000s and has received substantial acceptance among the smokers worldwide. And since a couple of years ago, the heated tobacco product has been introduced first in the Japan market in 2014, and since then on become available worldwide, including our country in 2018. So this have raised concern that these alternative products may limit progress in tobacco control efforts. So what is a heated tobacco product? It is one of the latest alternatives, and they are battery-powered or battery-equipped device that produce inhalable aerosol without combustion. That's the name, heated tobacco product, or heat not burn. However, and it comprises or it uses an actual tobacco product in the form of tobacco sticks, and this will produce the nicotine inhalable aerosol. However, they are different from the electronic cigarette, whereby the vape or the electronic cigarette do not contain tobacco, but typically contain nicotine liquid or salt. And both of these vape and HTP, they mimic smoking behavior. And on top of that, the HTP is different from the rest, from the conventional tobacco product, and also from the electronic tobacco because of the odorless and smokeless in nature, as can be seen in this picture here. It is from the IQOS, which is one of the popular heated tobacco product in the market, and in every puff, it produces very little amount of smoke. Since it does not involve burning of cigarettes, the chemical release from the heated tobacco product potentially to be less harmful than combustible cigarettes. And this table here showing the difference between conventional tobacco product, or we also can call it as the tobacco cigarettes, with the HTP and the vape, in particular the nicotine vaping product. And as we can see that obviously the conventional cigarettes requires lighter to burn the cigarette, as opposed to HTP and the electronic cigarette, whereby these are using the electronic system to heat either the tobacco stick for HTP or nicotine containing liquid for the vape, and all of them release nicotine in different forms, from different forms or from different source. And these are the three available HTP in the market: IQOS, Glo, and Plumtech, by different tobacco companies. And it comes with a heating unit here, and must be used with the tobacco insert in the form of either a stick. So here are example of the stick, and these are the capsule, either in the form of stick and capsule. Therefore, the heated tobacco product is still using the tobacco product to produce the nicotine aerosols. And they also come with various flavors here, as you can see now. And this product rapidly evolved and has now come with the third generation, with the technology and the software, and with affordable prices. And this is the situation in Malaysia, whereby we can get a starter unit less than 100 ringgit. And there's a premium tab as well. And as you can see, that's a very nice device here. And it's marketed as attractive design and packaging, appealing to the youth, so the young people may be attracted to use them. And it's available in major convenience stores such as 7-Eleven and most of our petrol gas convenience stores, as well as in the online platforms such as Lazada and Shopee. It is legal in Malaysia. The HTP is legal in Malaysia, and however, it's under the purview of Malaysian Tobacco Acts, such as must have warning sign or label and pictorial warning on its tobacco insert packaging. All right, so HTP is not a new concept. The technology underlying HTP product was initially developed in the late 1980s by R.J. Reynolds Tobacco Company, and in 1990s by Philip Morris International by the brand name Accord. Among other reasons, this product was retracted from the market due to their unpleasant taste and smell, not user-friendly, and also a limited availability in a few regions in the United States. And HTP were reintroduced, the modern HTP were reintroduced to the Japanese and international markets in 2014 by IQOS Philip Morris International, and 2016 Glo brand by the BAT, and Plumtech by the Japan International. This newer, better tasting and more elegant design, and they also commercialized as safer alternative to combustible cigarettes and as modified or reduced risk tobacco product. And currently significant use of HTP in few countries: Japan, South Korea, Italy, and United States. And Malaysia is the first country in Southeast Asia to legally introduce IQOS, Plumtech, and Glo from the end of 2018, and now widely available across the country. And the tobacco companies actively promote this product and make it trendy among young adults. Here showing the mechanism of combustible cigarettes. compared to different brand or types of heating mechanism or heated tobacco product, whereby the combustion or burning of the tip of cigarette produce temperature up to almost 100 degrees Celsius, and this will produce the mainstream smoke, which contains majority of the toxicant. Whereas in HTP, the temperature up to 250 degrees Celsius, and we have the heating source here, and here up to 350 degrees Celsius, to heat the tobacco insert. So these are the tobacco insert in the form of stick, and here is in the form of capsule. And for this type of HTP, the capsule, the tobacco capsule being heated indirectly and using the liquid medium from the heating element. One key element for HTP or HNP, it contains real tobacco, and the tobacco stick or the tobacco insert does not undergo self-sustaining exothermic combustion like the conventional cigarettes. Right, so a number of studies has been published with regards to HTP exposure by both tobacco industry, tobacco company, and independent research groups. And generally, the HTP emit reduced toxicant compared to conventional smoking, and the biomarker significantly reduced compared to active smoker. However, it's still harmful to our body, as indicated here on the right-hand side. There were increase in biomarkers of exposure with HTP compared to non-users. Right. With regards to toxic emissions, there were comparable level of nicotine release from HTP aerosol, similar to those of the conventional cigarettes, and some of the harmful constituents were significantly lower level, and some even comparable and higher level. For example, like all these three toxicant here, and some of them also in higher level. And studies in cell culture can provide mechanistic insight into any acute or chronic harmful effects associated with HTP use. Industry published studies do claim reduce cytotoxicity, mutagenicity, and low level of toxicological and inflammatory biomarkers after exposure of in vitro cells with HTP aerosols compared to conventional cigarettes. However, increasing HTP use, meaning that increasing in the exposure to the HTP aerosol, resulting in a substantial increase in these effects. More nicotine is delivered into cells exposed to HTP aerosols as compared to conventional cigarettes. And both industry and independent research studies showed that cytotoxicity, mutagenicity, and expression of certain RNAs are higher after exposure to HTP aerosol compared to non-exposure to any of tobacco product. And there were differences in the outcome measures between different HTP products, such as between IQAS and between group. As for animal study, there were lower dermal tumor incidence, fewer inflammatory and cellular stress response, and fewer histological changes compared to aerosol from combustible cigarettes. However, there were dose response relationship with HTP aerosol effects, meaning that there were increase in the tumor incidence when more exposure with the HTP aerosols. And of course, the incidence higher when compared without exposure to HTP aerosols. Therefore, why should we expose ourselves to harmful HTP aerosols? In agreement with the in vitro findings, exposure to HTP delivers more nicotine than conventional cigarette smoke in animal studies. Now let's look at what are the effects of the switch from smoking to HTP. Here are some of the effects, and industry publication report reductions in the biomarkers of exposure of certain constituents and less urinary mutagenicity. And in among smokers who switch to HTP, however, those who switch to HTP showed substantial increase, higher level of biomarker of exposure compared to those who stop smoking, and of course, compared to those who do not use of any product. In addition, the levels of biomarkers of cardiovascular and other diseases did not decrease, and in some cases increase after switch to HTP. And this suggests that HTP have similar or greater cardiovascular toxicity than conventional cigarettes. Lastly, HTP consumption and nicotine intake increase over time among those who switch to HTP, suggesting increase in their exposure to aerosol constituents from HTP. And research on passive exposure to HTP has been limited, and the result to date suggests that those use of HTP may expose bystander or the secondary HTP users to certain constituent at levels lower than passive exposure to conventional cigarettes. But of course, that would be a higher level of exposure compared to clean air, or not exposed to HTP, and even compared to e-cigarettes aerosols. And here, some of the implication of the HTP use. First, the product switching. So product switching to HTP or dual or poly product use. So people might use smoking and so using HTP, or they might also use with the e-cigarettes. Although industry data suggests that HTP could be used as a long-term substitution for conventional cigarette in highly controlled setting. However, independent population-based study raised concern that real-world concurrent use of cigarettes and HTP might prolong smoking behavior. And this is partly probably can be due to more nicotine being delivered to the cells. And additive potential of the use of the HTP, and significant levels of nicotine in HTP, similar to those of contemporary vaping products, suggesting abuse liability and potential for addiction. At the moment, the real world exposure and its effects on HTP users are not well characterized or unknown, or there were unique toxic effects of HTP that not yet been identified or well characterized. And reportedly, there were hepatocellular injury in response to HTPs, but not to conventional cigarette in experimental and clinical trials. And scientific evidence of HTP toxicity and long-term health effect is still accumulating, and big question mark on the long-term health outcome in users who switch completely to HTP or use them in combination with other smoking products. So we don't know what are the long-term effects of the HTP. And no reduction in the chronic disease burden, as mentioned in previous slide. Among a smoker who switched to HTP, data indicate no improvement in several pulmonary and cardiovascular indicators, and high prevalence of biomarkers among dual use with smoking in participants in switching studies. And increased risk of chronic diseases in a smoker who initiate HTP use. And because of the heterogeneity of the HTP product or the variation of the HTP brands, the data that we have now may not be applicable in the future. And this suggests that the technologies used HTP will continue to evolve, and changes in the chemical, for example, changes in the chemical composition of the aerosol, therefore the exposure and effects to users, and the wide variation among the products, devices, and their features result in the delivery of different levels of nicotine and toxicant, which has important regulatory implications. For example, if there is more tobacco in the product, or if they're also associated with the cannabis, and etc. And also concern about the second-hand exposure of the non-HTP users. And lastly, the perception of safety among users for those who otherwise quit smoking or initiate tobacco use. And this we can see with the electronic cigarette, whereby we have EVALI, the electronic cigarette or vape associated lung injury. And these are some of the policy recommendations to sort of regulate and control the use of the heated tobacco product. So we should continue to focus on the evidence-based measures to reduce any tobacco product, and to rely on the independent data and support continued independent research on the public health impact of the HTP use, to use existing regulations to regulate heated tobacco product product or to apply most restrictive tobacco control regulation on HTP. Currently, HTP has been banned in China and Hong Kong. However, it is widely available in Japan, and interestingly, in Japan, although they allow for HTP, but they ban any nicotine product, which meaning that we cannot vape in Japan. And we also need to have measures to require tobacco manufacturers to disclose all product information. For example, like the injury, the hepatocellular injury is not being well exposed, and we really need to know what are the data or information that's not being exposed to the public and to the public health experts. And also to prohibit all manufacturers and strategies from making claims about the reduced harm. So we cannot allow the tobacco industry to use the words reduce harm or modified or alternative to the tobacco smoking. And of course, we need to ensure that the public is well informed about the risk. All right, so in addition to this effect mentioned just now, HTP may emit chemicals that are not present in conventional cigarettes. So this is another alarming issue. And while HTP aerosol may expose users to low levels of some toxicant, it might expose them to high level of other toxicant. Therefore, it's important to independently assess the prevalent characteristic of HTP use. And these are some of the data from the Korea of 28 countries in the Europe, in the US, and also in the Japan. Collectively, HTPs by various brands have received well acceptance in these countries. And these are data from the 2020 International Tobacco Control Policy Evaluation Project, where we estimate that 25.4% of Malaysian adult smokers reported ever using HTP, with 14.8% of them are active users of at least monthly user of HTP, and most of them, almost half of them, were daily users. And these are the top 5 reasons why they're using the HTP. First would be the curiosity, because of the attractive design and packaging of the HTP, because of the good taste, appealing technology is a very handy, nice device, looking at it, just like our iPhone and etc. Attractive packaging, and some claim that it helps them to quit cigarette. However, it is a cross-sectional study. We need to have a longitudinal study to validate this, these reasons. And this is the first non-industry study to explore HTP use among Malaysian adult smoker, and this provides critical evidence for informing policies and regulation on tobacco product, educating the public and understanding the relationship between HTP use and cigarettes. And we know that the tobacco industry will always put a substantial investment to promote their product. Therefore, there will be a continuing need in Malaysia to track the use of HTPs, reasons for use, and switching or not switching to HTP from cigarettes. So I'd like to thank coordinators NARCC, Prof. Amir, Prof. Fariza, Prof. Andy, Prof. Amani, and members of NARCC for the opportunity for me to get on board with their research activities, and to the ITC project, University of Waterloo, Canada. And these are our collaborators. And that's all. Thank you for your attention.
Okay, thank you so much, Dr. Alfakri. That's a very interesting talk because you started off with all the different alternative tobacco products. It was interesting for non-smokers like us that, you know, there are so many products on the market, and they are really trying to sell these things. Okay, and so I really like your comment that, you know, we need to have this study done so that these companies don't overclaim about the safety of these products to users, because it's sad to see that there are also previous non-users who practically got on board with the heated tobacco products because they think it is safer than the usual cigarette. So we do have some questions for you here. Okay, Prof. Tengku Sara asked about whether you know that does shisha also contain nicotine?
All right, yeah. I'm not sure whether shisha contain nicotine. I haven't come across of that. But considering if there is any addictive potential from shisha, because it's a liquid containing is a liquid forms, so it's potentially may have nicotine. I think the question asks, does it contain nicotine? It potentially contains nicotine, similar to vape actually, because we do have, although a vape, we might think that it contains nicotine, but of course most of the vape contain nicotine, but we do have a non-nicotine delivery system, the ENDS, which is vape without the nicotine. Therefore, I think shisha goes the same way, whether some of them probably contain nicotine in their liquid and some with non-nicotine in their liquid. Yeah.
Oh, thank you very much. Okay, that is enlightening to me too. Okay, Prof, you said, I believe the HTP could be more expensive than normal cigarette. Do you know if there is any demographic difference between HTP and conventional users?
Okay, all right. So first, whether it's more expensive, because the HTP comes with a unit, so you need to have the starter unit, the heating mechanism, and that costs you about less than 100 ringgit. And of course, the users need to buy the tobacco insert as well in addition to that, and if we add that, yeah, probably it's more expensive, but we do have a substantial acceptance of HTP among Malaysian smokers. And with regards to demographic difference between HTP and conventional users, yeah, we do have a published data whereby we see that the HTP is more common among those with a higher socio-economic status, for example, like those who are more with higher income background and also higher education background. But we need to look at our own data, whether this is true or not. So we do really need to have a good data, in particular to Malaysian perspective. But of course, for example, in Japan, we do have, and also I think in German, there was studies saying that this product were popular among higher socioeconomic status background. Yeah.
So it's also some kind of a status symbol. Okay.
Yes. So, yeah.
So there's another question from Prof. Kamala Kanan. We're just wondering whether there's any difference between HTPs and the e-cigarette, the vape. Okay. Is there any difference?
Yeah. So I think, yeah, there is a difference. I think in my earlier slide, I showed the difference between HTP product and the e-cigarettes, or probably the best terminology to use for vape, for e-cigarettes, the one which earlier introduced is the nicotine vaping product. So that is the e-cigarettes that we are referring to, and they produce a lot of smokes, as we as we realize that, and whereas the HTP are smokeless and odorless. So it does not produce much smoke as compared to e-cigarettes, and even compared to the conventional tobacco cigarettes. Yeah.
I see.
So it's a smokeless for HTP.
So in terms of harm, is there any difference between e-cigarette and HTPs though?
All right, so because heated tobacco product use tobacco insert in it, so if we compare HTP with nicotine vaping product, of course, HTP will be more harmful as compared to e-cigarette. This is obviously because of HTP contain the tobacco insert in it, and of course, nicotine vaping product or vape, although we can say is sort of safe in terms of no tobacco containing device. However, we do have cases, for example, like e-cigarettes and vaping associated lung injury, and that pose a different kind of harmful or dangerous to our body. Yeah.
Okay, so this is my own question. I'm just wondering that with all this technology, is there any possibility that we can actually use HTP to promote cessation of smoking? Is there any possibility, maybe in the future?
Yeah, I think I've mentioned also that the industry-driven study in a control setting found that HTP can potentially substitute or replace cigarette smoking altogether. However, with regards to EC as well, although it can be potentially as a smoking cessation tool, however, it can actually prolong smoking behavior, because we have a study saying that the nicotine will be delivered to the cell and to the animal study even more as compared to conventional smoking. Therefore, if there are more nicotine being delivered, we can say that the they will prolong smoking addiction, or even even users with non-smoking user, but using HTP at the first place, they may end up become a cigarette smoker. This is because of they might feel dissatisfied with using the HTP and even the e-cigarette. They may eventually become a cigarette smoker. Yeah.
Sure, cigarette smoker. Okay, so there's really a lot of things that we don't really know. Even as doctors, we don't really know what to advise our patients with regards to all these new technology regarding cigarettes. So thank you so much, Dr. Alfakri. This had been very enlightening to all of us. And thank you so much, everyone, for joining us in breakfast at UMHealth for the current session. Thank you very much. We shall end the session now. Bye.